I am here to talk about a framework for understanding opportunities in value-based care. Um, I think probably everybody in this room is familiar with, on some level, with value-based care principles and has a recipe that they would advocate for success. This is Arcadia's recipe, and I'm a big believer in it. Frankly, the first time I saw this framing, it really grabbed me because I think it hits at the fundamental principles, which is to say optimizing the value equation in healthcare, and then takes a step past that to sort of strategic pillars that are easily understandable. And what we are in the process of doing is then building out tactics for each of those pillars that allow our customers to identify synergy with their existing strategy, help them contextualize their VBC journey in the region they're in or in the payer environment, the competitive environment they're in. So what I'm going to take the next 5-10 minutes doing is walking through this framework, and then I would love to just have a little bit of dialogue about everyone's experiences in domains that are of interest to you, and what you think key tactics are that we might be able to steal and add to our framework. So the first thing I'll say about this framework that I think is super important is that it's balanced, which is to say success is a function of optimizing revenue and value, but also of minimizing avoidable cost. And I think that speaks to the terms in the value equation. It also sets up an opportunity for dialogue with stakeholders outside of a traditional VBC segment of your organization. Many provider organizations in particular talk about this foot in two canoes analogy, right? So you're trying to adopt a value-based paradigm, but the fact of the matter is, for many health systems, they're still getting most of their revenue in traditional ways through fee-for-service. And the key stakeholders to get approval to advance your VBC agenda are living in that world. So as a VBC team leader, you might have both feet in the value canoe, but you're working with partners who might really have 80% of their weight still in the fee-for-service canoe, and they're like, putting a leg out into value. Addressing those folks in terms of the revenue opportunity, I think, is really a critical communication opportunity. And so what are these pillars that you see here under the revenue opportunity? Design and refine contracts. I think that folks on your network team or folks in the finance office are very familiar with the critical importance of creating payer agreements that are favorable to you in a fee-for-service paradigm. Well, I think we understand that the same opportunity exists in optimizing value-based care contracts, right? Now, the sort of the levers or the categories that you want to be sure you get favorable terms on might be a little different. Quality programs in VBC contracts are weighted much higher than they are in a traditional contract, which might not even have, several decades ago, there might not even be a quality term in a standard agreement. So know your strengths, play to your strengths in terms of quality. As an example, if you know that you have ample capacity in your GI service line and you can get people in for screening, colorectal cancer screening, make sure you get highly rewarded for that, because you're not going to have people waiting. You're going to close gaps faster. And to that point earlier about speaking to stakeholders that are living with a foot in two canoes, in the fee-for-service canoe and the value canoe, those colonoscopies are revenue for that service line, right? That is revenue that will appeal to other stakeholders in your organization who might, frankly, not have as much weight in the value canoe. Optimizing networks. I don't think it's as simple as saying make sure you have the right people on the bus, but that's the catchphrase here, right? Like, you're going to be successful if you're playing the game with the right team. So how can you do that? You can use internal data, your first-party data, to look at outcomes within your existing network. But then you can also use third-party data. There is publicly available data that will let you look at other providers in your community and identify those that are performing in a way that is very conducive to success and value. So a classic example would be an orthopedic surgeon who's instead of sending low-risk patients to an acute rehab destination post-discharge after an elective hip or knee, they're using sort of a right-sized therapy approach, which could be outpatient therapy, at a facility, at an ambulatory PT facility, or even in the home. But either way, it's a much more rational use of resources than acute rehab, and conducive to success and value. So figure out who your right docs are, your right providers are in your network. And then lastly, and I'm not going to belabor this point, at least in the conventional sense, you have to make sure that you're capturing the risk of your membership, so that in value-based care agreements, where risk-adjusted revenue is the revenue, you're being paid appropriately. And one thing I'll say about that is, on the point about coding, a point I often make to physicians who are being asked to pay attention to this, and often are feeling like, well, this isn't really patient care. This is an administrative job. Why do I have to do it? And the reason that they have to do it is because by coding accurately, you're creating appropriate revenue to pay for the services that your patient needs clinically. So it is really a key part of making sure your patients get what they need. The other thing I would add to this point, and it's a nice segue to the other side of this diagram, is that in addition to the code capture conventional definition of accurately addressing risk, increasingly a broader definition of risk that includes an understanding that there are many variables outside of what would be captured on a claim that determine health outcomes is a critical consideration. So, with that in mind, I'm going to flip over to the other side here, become my alter ego on this side of the screen. So these are our pillars for managing cost and utilization. Top of the list here, enhancing physician performance, and that is a category that has been a part of the value agenda for some time. And as there's sort of a hierarchy, a maturation model for healthcare value. At the very beginning, I would say a value transformation of our industry's journey there. Physician accountability for quality was maybe the first thing that happened, right? Like sort of making sure the HEDIS measures and quality reporting generally, as I said earlier, is now a standard part of fee-for-service contracts. There are quality expectations. But to really get to the next level and optimize the overall value equation, you have to optimize physician performance above and beyond HEDIS measures. And that includes things like patient experience. It includes tracking patient-reported outcomes. So not just are patients getting colorectal cancer screening, I alluded to earlier, or getting services appropriately, but what is their experience of being a patient like? Do they feel better? I would argue that if you can help your physicians achieve outcomes that include patients feeling better, that will serve your system well. Getting back to that point earlier about how we interface as a value-based care entity with fee-for-service stakeholders who have a foot in the other canoe. At the end of the day, happy patients who feel good are going to be any health system's best friend in terms of expanding their business, right? For all the billboards, everybody I know goes to the hospital that their friend told them, treated them well, treated them respectfully, and made them feel better. So, enhancing physician performance, absolutely HEDIS performance optimization, but a broader understanding of that is really what will propel you forward. Whole person care, this again, I mentioned patient-reported outcomes. There are many domains of patient health that go beyond HEDIS measures. And I think that's kind of the takeaway that I want to be sure we understand, is that it's not just, we shouldn't be teaching to the test in terms of quality. We should be considering what it's like to be a patient, how it feels to get better, making sure people are realizing that, patients are realizing that, that perceived benefit. And that means that we have to understand not just what their diagnosis is and what the right treatment is, but what's leading them to use healthcare, or what's leading them not to use healthcare. Maybe more importantly, the barriers that people have to care, whether it's a geographic barrier, they're distant from the hospital. We need to address that. Whole person care. There might be cultural barriers, language barriers. We need to address those things so that patients feel that we know them as an individual and not just as a patient. And that will bring them into our health systems in a way that will be much more productive than if we're treating them solely as a diagnosis or even as a patient without considering their whole context. And then lastly, optimize utilization. So I spoke earlier about sort of that ortho episode and the appropriate utilization of post-acute services. That is absolutely, site of service is absolutely fundamental. There are huge opportunities, really every year, more opportunities to have services that were once exclusively based in hospitals be done in other settings. And that's true for procedures. It's true for imaging and other diagnostics. I think there's a real fundamental need to optimize utilization there. So, when you put all that together, you're going to yield best revenue at the most appropriate cost and success in your VBC arrangements. So I previewed earlier that I was going to kind of move to the last section of this and ask, does anybody have specific tactics that they want to share on any of these arms for discussion?
There's a nice amount of overlap between these. I love the concept and the framework. But how does Arcadia specifically think about bringing the two worlds together? Because you have adequately addressing risk on the left, driving revenue, enhancing that physician performance. And how do you, while thinking about these as key domains, actually make it streamlined and easy?
Yeah, thanks. So the reality is that to the extent these are strategies, they map to tactics, and each tactic has a different operational lift associated with it. Some tactics are relatively easily rolled out. So, for example, if you're going to use third-party data to look at physician performance in your community, you put the NPI in, you find out what the physician performance is, and you can very quickly know where the performance opportunities are. In contrast, whole person care, if you're going to put in sort of the robust social supports, if you're going to curate a community-based organization network of preferred CBOs, that's a much longer pull. So to answer your question about how do you integrate this all, I think it takes a thoughtful, intentional process to say, we have a set of tactics in our organization. We have a set of strategies. We have a set of tactics that will very quickly yield ROI. We also have key tactics that are going to take a year or 2 years to bear fruit. And so up front, what we do with our customers, up front, we lay that all out and we create a roadmap that's mindful of the fact that, the fact is a VBC organization within a larger health system needs to demonstrate value as soon as possible in order to facilitate further growth of their agenda as part of the larger portfolio. But then also to really optimize the equation, you can't take your eye off some of these things that are going to take 2 years, 3 years to show a demonstrable ROI. So I think it's about intentionality and the recognition that there are short wins that are totally appropriate, and then there are longer wins that you have to do in parallel. Yes.
It is loud this time. Just to share a little bit of a patient anecdote here. It's nice to see that in this value formula that we're not just focused on the P&L, which things like optimizing your contract, yes, that's the necessary, right? But that we are also not losing sight of delivering whole person care. For me personally, my mom needed a procedure during COVID times when you couldn't have guests in the facility, in the hospital with you. You drop them off and then you get a text alert, come pick her up, 5 hours later. Could be 5 hours, could be 10 hours, depending on when they got her in. She doesn't speak English and she's only comfortable speaking a dialect of Chinese. And it really helps put my mind at ease. Of course, I'm selfishly thinking about myself, but she's probably even more terrified being the patient in that operation room. But they were able to eventually call somebody in and say, which dialect of the millions in Chinese do you speak? And just that little extra bit of attentive care means the world. And so it's just really nice to see that value-based care or not, or even in the health system facility, which is very still fee-for-service oriented, like you mentioned, that there's still that human element of it.
Yeah, absolutely. Some of you might have been here yesterday. We did a session on precision medicine and personalized care. I use those terms, probably I take some liberties broadly, to include patient-centered care as well. And I think we hear a lot about patient-centered care now compared to 10 years ago, which is sort of, I think, what your story brings me to, the fact that we need to meet people, and I said this earlier, we need to meet people as who they are. I mean, I think of parts of my career where I've been an educator, you got to meet people where they are. And if you don't, if you meet them as who you are, I mean, that'll work if they're like you, but the world is not simple that way, right? People are different. So I guess the thing I would say to tie that to Arcadia's work is that a lot of those factors that make someone who they are as a person are actually, they have a digital signature of that. There are characteristics of where you live, how you use healthcare that can be abstracted, and we can personalize care around those things. It could be something sort of abstract, like the environmental, the pollution load where they live. We've done work looking at when there are wildfires, how that affects asthma rates, and actually deployed notifications to those individuals specifically who are at risk for asthma flares, who are in an area that is being affected by wildfires. And it can also be things that are, I would say, even more personal than that, sort of considering people's spiritual preferences, or the relationships they have with caregivers, and making sure we bring caregivers in appropriately as part of the dialogue. So all of those things, I think those are, really provider competencies. And I think provider organizations have come a long way in all of that. And I would consider it a challenge for Arcadia to figure out how to leverage that with a digital signal so that we can, some of it is very hard to imagine automating, but we certainly should be able to prime the pump in a way that hasn't happened in the past, so our provider partners can more easily recognize somebody, like I said, as an individual for who they are, and not as, a heart failure admission or whatever. All right, folks, we're at time. Thank you very much for your time today.